There, I see we're live. Hello from Group 4. Our group members are Courtney Powell, Michael O'Neill, and I'm Janet Place. We will be discussing the culture care of 3 groups, Indian, Amish, and Filipino. We hope you enjoy our discussion. Courtney, would you like to start with your presentation of the Indian culture?
Yes, I would. Thank you for the introduction, Janet. I'm Courtney Powell, and I'll be discussing how to provide culturally sensitive and respectful care to people from the country of India. Before reading about healthcare practices in India, I did not have much personal nursing experience involving Indian people. As an officer of the United States Navy, however, I may have the opportunity to travel abroad and provide humanitarian support to countries and people in need. Understanding the beliefs, values, and cultural practices of the Indian people will assist me in providing culturally competent care in the future.
So, Courtney, what types of health care are available to the people of India?
Well, India is a very diverse country in both its resources and its people. While there is privatized and Western modern health care available in the large cities, much of the population is poor and lives in rural areas, often with limited access to health care. Non-governmental organizations frequently provide care for those people who cannot afford health insurance or privatized care. And in addition, the Indian government also offers health care to those who cannot pay for treatments out of their own pocket. People living in rural areas with limited access to transportation and healthcare facilities often practice generic or indigenous health care. India has the largest educational and research institutions for the study of homeopathic health systems. There are thousands of trained midwives, bone setters, and herbalists practicing in India. Often medications are created from the use of plants, leaves, seeds, and flowers. Nature and healing are often connected in generic health practices. In addition, Indians practicing indigenous healthcare believe that the patient, rather than the illness, is the focus of the diagnosis. There are many cultural practices that healthcare providers should be aware of when offering treatment to an Indian patient. Village unity and kinship of family is important. The Indians have much respect for their elders and may request presence of family while receiving treatment. This is not very different from the healthcare in the United States, as we are focusing on the importance of patient and family-centered care as well. Indian families are also patriarchal, with importance placed on the man and his wealth and status.
If Indian families are patriarchal, what does this mean for the Indian women? What kind of cultural beliefs must be considered when we're caring for the Indian women?
Well, among the Indian population, approximately 81% practice Hinduism and 12% practice Islam. Many Indian women participate in veiling or wear traditional hijabs to display modesty. While providing health care to an Indian woman, it is essential to maintain that modesty. It is also important to realize that Indian women are more comfortable when receiving care from a female nurse or practitioner. Unfortunately, in this patriarchal society, Indian women are often not treated with the same respect as men. It is important to recognize signs and symptoms of abuse, violence, or nutritional deficits when caring for Indian women. The healthcare provider must also understand that the Indian woman may need to consult her spouse before making a healthcare decision. The important thing to remember is that not all Indian people are the same. Different regions of the country, different religions, and different values all yield varying cultural beliefs. Be culturally sensitive and remember to ask the patient what his or her values are regarding health care. Next, Michael will discuss health care among the Amish. Michael, earlier you stated that there were some similarities between the Amish culture and the communities of the homeless. Will you remind me of the points you brought up?
Sure. The information I was able to give both of you was derived from commentaries from Dr. DeLine and Dr. Eastman. Not to be forsaken for any glory, the Langer's Transcultural Nursing publication, Chapter 32, really provided the glue to allow these two cultures to be focused within a single lens. Like the homeless, the Amish community live a very simple life. Many of the Amish live their lives without the use of electricity, and they travel by horse and buggy. Their education level is ranked at, an 8th grader at best. The values of the Amish community is heavily weighed. The Amish promote community life over that of individualism as a way of survivability for its culture. The resultant of such a view produces contentment for the group that supersedes that of an individual. Like that of the homeless community, networks have tight bonds, and many times survival of an individual depends on the means of its community it's attached to. Similar to the homeless, the Amish focus their healthcare needs on the current problem and not that of a potential problem. This is of special note to women who are pregnant. Oftentimes, medical attention isn't sought out until the 34th to about the 38th week of gestation. The interest of diagnostic testings for both groups is not founded in just identifying a disease. However, both groups are extremely concerned about the results, what they will mean for them and for the communities that they are attached to. Both groups are concerned about meaningful treatments, which allow them the opportunity to continue their learned survival techniques. Utilizing Laringer's theory of culture care, it is extremely important as nurses that, in taking care of these patients that are embedded in these communities, that we don't try to take over their decision-making process, regardless of our perceived innocent motives. We want to preserve their decision-making strategy and cultural life. Because of their entrenched belief systems, it may be in the provider's favor to utilize the cultural care negotiation practices to encourage preventive health maintenance, much as timely prenatal care is an example, or maintenance of such. Last but not least, it is very important to stress that when a provider is attempting to restructure the health behavior of an individual in these two communities, incremental health recommendations should be encouraged instead of large life changes.
Courtney and Michael, I see the correlation between the two cultures. I can only imagine the number of homeless women who are pregnant and who do not seek prenatal care. Being judgmental on their survival techniques when they finally do seek treatment would not promote healthcare restructuring in their lives.
So Janet, why did you discuss the Philippine culture?
Well, I chose the topic of the Philippines because I lived there and I've worked with several Filipino nurses. There's a difference when caring for and with this cultural group. Several cultural care values were expressed in Leininger. In particular, Filipinos want to maintain smooth and harmonious interpersonal relationships and to get along with others. They value personal esteem, honor, and saving face. They expect personal obligations to be repaid by mutual reciprocity. We call this now paying it forward. And they tend to have a strong belief in putting oneself in the care of God. These values can all be incorporated into preservation and maintenance in Leininger's culture care theory. When caring for a Filipino client, give proper respect and maintain harmony. Address an elderly patient formally, use a firm handshake with a smile and eye contact, and provide care in a gentle, quiet, and respectful way. Avoid any remarks that would shame the patient, especially in front of others. For instance, do not reprimand the patient for not taking medications, for instance, but provide information as to the need and benefits of taking the medication. The Filipino client tends to respect authority, and we as nurses and other healthcare workers represent authority. Be cautious with that authority and make sure to include the patient's wishes in the decision-making process. Does that make sense?
Yes, Janet, it does. What are some of the differences you found when working with nurses from the Philippines?
There are some marked cultural differences when working with Filipino nurses. American nurses have been acculturated to be assertive, individualistic, and goal-oriented. Filipino nurses, however, by culture are more passive. They value smooth working relationships, work slowly and methodically, defer to those in authority, and see the American culture as demanding and brassy. This can become a conflict when working as a team on a care unit. Knowing ways to avoid these conflicts can be helpful, especially when in a supervisory role. Direct criticism, especially in front of others, is unacceptable to a Filipino, as it does not maintain self-esteem and respect. Mutual sharing and discussions among team members about style differences of Filipinos and Americans may help reach an understanding. The Filipino American Nurses Association of America, the PNAA, is a good resource for investigating cultural differences. So colleagues, that concludes our discussion on the Indian, Amish, and Filipino cultures. Thank you for listening, and we hope that you have gained some insight into the three cultures we have presented, and that it made you a little more prepared to care for your patients and interact with your colleagues in a productive way. Bye for now.